I'm Dr. Victoria, and this is George.
Today, we are going to talk about the COVID-19 virus. For the past few days, George has not been feeling well at all. He had a little bit of cough that was dry and a bit of a sore throat. He thought maybe he felt feverish, and he definitely had some body aches. He even started having a bit of diarrhea. For the most part, it feels like a cold he has had in the past. Well, maybe the diarrhea is a bit different, and he does have a hard time tasting and smelling things right now. Since everyone is so worried and keeps talking about this COVID-19 virus, he thought maybe that could be what was going on. Come to think of it, he hasn't been wearing his mask properly, and he forgets to wash his hands regularly. What is happening to George is that his body has been exposed to a coronavirus, an enveloped positive stranded RNA virus. This virus likely started as being one that only affected bats and then was transmitted either directly to humans or through some intermediate host to run rampant among the human population. Different modes of transmission include respiratory droplets. This can be done in an aerosolized manner through speaking, coughing, or sneezing, or by touching contaminated surfaces and then touching the eyes, nose, or mouth. Maybe it was that grocery cart that George did not sanitize, and then he kept touching his face because he had an itchy eye. Patients may complain of cough, fever, myalgias, headache, dyspnea, sore throat, diarrhea, nausea, vomiting, loss of smell or taste, abdominal pain, and rhinorrhea. Or there may be no complaints at all, as there are many people who do not have any symptoms and yet carry the virus and are actively shedding it so that others will be infected and may or may not have symptoms themselves. On exam, it really depends on how bad the infection is in the patient. They may be completely asymptomatic, or the vital signs may show that they have increased oxygen requirements. On pulse ox, they may be saturating too low on room air, less than 94%. The lungs may sound, well, really not that bad, especially when you compare them to the X-ray findings, and the X-ray does not look good at all, usually in an atypical pneumonia pattern. Comorbidities that would predispose someone to have severe illness and poor outcomes include those of older age, think more than 65 years old, cardiovascular disease, diabetes mellitus, hypertension, chronic lung disease, cancer, chronic kidney disease, obesity, and smokers. I'll be using some guidelines from my facility to talk about how we treat different stages. Since we are still learning about COVID, our guidelines may differ from what healthcare professionals are doing in your region and may change as time goes on. For asymptomatic patients who test positive but have no symptoms, we recommend zinc lozenges, vitamin C, melatonin 1 to 2 milligrams at night, vitamin D, and an optional addition is famotidine. This is not a proven treatment, but they are some recommendations that may be helpful. For patients who have a mild illness, they may have fever, cough, sore throat, malaise, headache, muscle pains, but no evidence of lower respiratory tract illness nor abnormal imaging on X-ray. For these patients, we recommend albuterol, antipyretics such as Tylenol, a cough suppressant, benzonatate, or promethazine, and antidiarrheal if that isn't a symptom. And we can consider adding on zinc lozenges, vitamin C, vitamin D, melatonin, this time 6 to 12 milligrams nightly, aspirin 81 to 325 milligrams per day, and that famotidine. And I'd like to encourage patients to be active and move around as much as they can by changing their position every 30 minutes to 2 hours, whether it is sitting differently, laying on one side than the other, so that we can help prevent the development of venous thromboembolisms. We recommend to these patients at home quarantining that they should monitor their breathing. It would be ideal if they could check their oxygen saturation with pulse oximetry. If the pulse ox is below 94% on room air, or they have worsening shortness of breath, we recommend that they go to their local emergency room. Say this patient ends up in the local ED. If it is in the first 10 days of the onset of symptoms, we would recommend a one-time dose of a monoclonal antibody, such as bamlanivimab, or casirivimab, or imdemivimab. If they are presenting in the second week of symptoms, we recommend a steroid, methylprednisolone 40 to 80 milligrams IV, followed by Medrol dose pack, or dexamethasone 4 to 6 milligrams IV, followed by a dex pack for 10 days. As well, we should evaluate the patient for their risk factors of developing a venous thromboembolism. We do not have evidence to support the use of thromboprophylaxis in COVID-19 positive patients who have not been hospitalized, but it is still done at times. I've often seen patients that have been home getting better from their respiratory symptoms when all of a sudden they are short of breath again and they are coming in for a pulmonary embolism. For discharged patients, if they have had no venous thromboembolism and their D-dimer remains less than 3 mcg, or if it has been greater than 3 at any time during their stay, some options would include rivaroxaban, apixaban, or a prophylactic dose of enoxaparin. If there were no new or suspected venous thromboembolisms, they should have one of these medications given for 3 months after discharge. If someone has a moderate illness, they have evidence of lower respiratory disease to clinical assessment or imaging and oxygen saturation greater than 94% on room air. If we have a clinical suspicion that they are quite sick, we should just send them over to the emergency room. We may want to do some labs to look for inflammation. Laboratory exams include CBC, CMP, CRP, ESR, ferritin, LDH, and D-dimer. Imaging includes a chest X-ray or even a CT may be needed, a CTA when we need to look for a PE2. If there is no elevated inflammatory markers or multi-lobar involvement on imaging, we recommend outpatient treatment with close follow-up in 2 to 3 days via telehealth. We may need to repeat labs and imaging. If we find there is indeed elevated inflammatory markers or on imaging we see multi-lobar involvement, we recommend sending them to the emergency room, or if you can directly admit them, that would be best. They may need IV remdesivir and steroids if they require supplemental oxygen. For severe illness, patients may be tachypnic, having a respiratory rate greater than 30, oxygen saturation less than or equal to 94% on room air, the ratio of arterial partial pressure of oxygen to fraction of inspired oxygen less than 300, or a lung infiltrate greater than 50%. This patient should go ahead to the emergency room, or if you have a doc in the loop, you can do a direct admit. For patients who have left the hospital or maybe did not need to be there at all, we can follow up via telehealth once again. We should evaluate the signs and symptoms of COVID, evaluate the need for anticoagulation. COVID-19 puts you in a hypercoagulable state, so there is a higher risk of developing deep vein thrombosis or pulmonary emboli. As well, we may need to evaluate for the continuation of steroids. For George, he does not feel good, but I've got a little pulse ox here at home and he's saturating okay. He can move around okay. He's not that old, and if he does not have a whole lot of comorbidities, at least not right now, you know how hanging around me, George gets put through the ringer. If he has worsening symptoms, especially worsening shortness of breath, then he should reach out to his doctor. But in the meantime, he will be okay to stay at home. He will keep himself closed off from other family members. He will get his own bathroom to use, and someone can leave him some meals outside his door so he's not touching everything and spreading the virus to those he cares about. He can do close follow-up with his favorite family physician via telehealth, where he can share his concerns and his progress. Thank you for joining me today, my healthcare team. This virus really has monopolized our healthcare system and turned all of our worlds upside down. But I know I have seen such great compassion and teamwork in so many avenues of life. I hope we can take the time to highlight the positive aspects, even though there has been a great deal of sorrow. I hope you will join us next time as we find out what George gets up to next. Bye-bye.